Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is brought to you by AACN's online nursing community forums, offering support, inspiration, and sharing of best practices online, with information available at www.aacn.org/AACN communities. Now, here are your hosts, AACN's Chief Clinical Officer Vicki Good and Clinical Practice Specialist Andrea Schmidt.
Hi, this is Andrea Schmidt, and welcome to the Voices in Nursing podcast. I'm joined today by one of my fellow AACN nurses and podcast host, Sarah Grisham.
Thanks, Andrea. It's so great to be here today with you on this podcast. I'm so excited for our guest. Incivility is something, as nurses, that we have all experienced in some way, shape, or form. And I think that today's guest has really tackled this, and I'm really excited to talk to her.
I'm excited to talk about this topic as well. I feel like there's a lot of things that occur in nursing that people may not even think are being incivil towards one another. You know, something as simple as a small comment or snide comment that maybe they just think they're joking around, but it really is not. And I think when these things start adding up, this really creates a persistent barrier to having a healthy work environment.
It really does.
So I understand that you used to work with our guest, and I was wondering if you would like the honor of introducing her.
Absolutely. Our guest today, Shalanda Perkins, she is the Assistant Director of Nursing Education and the Buckeye Nurse Residency Program Director at the Ohio State University Wexner Medical Center. And I'm really excited to talk to her again because she's tackled this problem head on. And I've actually attended this course in person with her. She's come up with some really innovative strategies that will help address incivility in the workplace. So Shalanda, let's get started. Tell us about yourself.
Thank you guys for having me. Like Sarah said, I am the Associate Director of Nursing Education for the health system. I'm also the Director of the Buckeye Nurse Residency Program. I've been a nurse for about 20 years. 20 years. A lot of my last 10 to 15 years, I have spent really looking at incivility from an academic perspective. And then when I was working on my DNP, this really carried over into my practice change project in combating incivility at the bedside. It's followed me. I do this training and awareness raising across the entire enterprise, and it has only further just garnered attention from even other hospitals in the local area.
That's really great. Is there any particular thing that really sparked your interest in addressing this issue? Anything particular that happened to you or that you saw? Because as we mentioned in the beginning, it can happen to anybody and it can be so little or something so much bigger.
Absolutely. I remember being a new graduate nurse, and I worked at a level 1 trauma center in Indianapolis. It was wonderful. I thought this was a great opportunity. I was in a med-surg fellowship program as a new graduate nurse. I had the most amazing primary preceptor. I always tell my groups that she was very grandmotherly. She met me at hospital orientation with chocolate chip cookies, and they were still warm.
That is amazing.
Yes, I don't know how that happened, but they were. And I thought, I'm in a new state. I'm in a new profession. How in the world did I get so lucky? And I remained lucky until I wasn't, which happened to be maybe a month or so later when my primary preceptor broke her ankle. And what proceeded from there was the epitome of nurses eating their young. You know, we hear about that a lot, but I don't know that you actually know what that looks like until you've experienced it firsthand. But it took me through some very formative time in my early career to the point where I second-guessed everything that I did. I wondered, am I even smart enough to be a nurse? Can I do this? I'm already frightened that I have people's lives in my hands, but now I go to work and I feel physically ill. I don't sleep well. I truly thought that I might be pregnant. I couldn't account for many of those physiological symptoms until I really, truly looked back on it and I realized this was workplace bullying. This was incivility. And it almost forced me out of nursing altogether. And so when I journeyed into my master's program and I knew that I was going to have to choose a project to focus on, I thought, I don't ever want to be that guy that treats another person like that. So I want to know the root of it. I want to know what are the evidence-based interventions and what can we do on an individual or organizational level to combat incivility and stop it in its tracks.
And it's so real because, whether you were working through the pandemic or whether you've been a nurse for, 30 years, every single one of us has a story where we felt belittled, where we felt, like you said, unsafe. Am I even smart enough to be here? And that is the worst feeling ever. So I loved how you called it raising awareness. And it is so true. And I remember one of the things that you said was say what you mean, don't say it mean. So tell us a little bit about that and the program you've designed.
Well, that is kind of my motto. Say what you mean, but you don't have to say it mean. And raising awareness is just stage one of combating incivility. The literature defines incivility as rude or disruptive behaviors. That definition comes from Dr. Cynthia Clark. If left unresolved, it could potentially progress into physical violence. So how are we going to define what this behavior looks like if the definition in and of itself is so subjective? So the very first layer of civility education is raising awareness. What does it look like? What does it feel like? And I ask every group to identify in their own words, what are some acts of incivility that you've experienced, all the way down from those low-risk behaviors like eye rolling and heavy sighs, closed-off body language, all the way to the other end of the spectrum where people are concerned and fearful for their physical safety. That's just step one. Step two would then be training people, individuals on the units and other leaders at the department level to be peer coaches and to be mentors and to be those boots on the ground individuals that can help facilitate good conflict resolution in the moment. And then where's the leadership training? That is so huge. When I got here and I started, on this crusade of just combating incivility, what I realized is that everybody knows the word. Nobody knows what to do to fix it. And from a leadership perspective, our managers, assistant nurse managers, and even directors were kind of at a loss. How do I manage this? What do I do once it's been brought to my attention? And so that's another layer of the civility program that we've built in to help stop the problem where it's starting.
I think that is so great. And I'm really excited to hear more about your program. Something that you just said about the leaders, they don't know where to go with it or what to do with it. And I think sometimes there's also this fear of letting go of a good nurse. But how good are they if they are mean to somebody else? They may have the best skills on the planet, but if they're just treating everybody so poorly, where it becomes almost like a cancer on the unit, how do they handle that without others getting mad at them for letting that great nurse with those great skills go? And I think I've seen that in my own workplace. And so I'm looking forward to hearing more about some of that if we have time.
Absolutely. I think cancer is a very good way of describing it. It does become an extremely pervasive tumor that if you don't eradicate it very quickly, the entire culture is diseased.
That doesn't do much for retention, does it?
Not at all.
So What I do want to touch on is this tool you utilize that's called cognitive rehearsal. And that is supposed to help nurses prepare and respond to these incidents of incivility. So, could you describe cognitive rehearsal and give us an example of how it works, or maybe even do some role playing with us?
I love that. Absolutely. So, cognitive rehearsal is a cognitive behavioral therapy. It is essentially memorized assertive phrases against very common acts of incivility. I'll just give you an example. One of the statements is in response to nonverbal innuendo like eye rolling. For me, eye rolling it makes me twitch. It is like a proverbial slap in the face. It is the ultimate sign of disrespect, in my opinion. And the cognitive rehearsal statement against eye rolling would be, I get the sense from your body language that there's something you need to discuss. Please feel free to talk to me openly.
Oh, I like that.
And I've actually seen Shalanda use that when we were in a skills lab once with a brand new grad who very much rolled those eyes into the back of her head. And it worked. It really worked.
Oh, I remember. I think that caught her off guard, and instantly she was apologetic. Oh, I'm sorry. And then she gave a lot of explanation as to why that was her nonverbal language. But again, it's my responsibility to raise awareness of what those behaviors look like. We have to hold each other to a standard of professionalism, and not everybody's comfortable to do so. But when we give them tools like cognitive rehearsal to place in their toolbox, even if it's an emotional situation, if you are utilizing the tool the way in which it's intended, it's effective almost 100% of the time.
Do you want to try one? You want to do a little role play?
Let's do it.
All right, you pick the scenario.
Let's try, how about name calling? This is an example that has come up recently in a couple of situations, unfortunately, between providers and our staff nurses. We had a situation in which an advanced practice provider, without using the word stupid, because she didn't say stupid, but all of the language that she was using and the tone of her voice and her body language implied that the nurse that she was talking to was dumb or incompetent to care for the patient in which she was caring for. There was a request from the staff nurse for a different set of orders given the patient's condition, and that's when the nurse practitioner unleashed a tirade. My response in that situation is, I learn best from people when I'm treated with respect. How can we structure that type of interaction?
Well, I'm going to start. I'm going to call you a cotton-headed ninny muggin.
Oh,
Yep.
That hurts. Sarah, I'm a little uncomfortable by the exchange that you and I just had. When I hear language that makes me feel disrespected or demeaned or even embarrassed, I do want to seek out a deeper level of understanding. Can you help me to understand the intention behind your words?
You're right. I spoke without thinking and used the moment versus taking a step back and breathing before speaking to you as a colleague and as a partner in this patient care.
Wow. Thank you so much for that level of accountability. Hopefully, we can work together in the future. And if there's ever something that you need to discuss with me, or if you feel as though maybe there's a knowledge or a skill gap, I would love for you to come to me. I know that I can be a good nurse, and with your help, we can better care for the patients that we're assigned.
Wow, Shalanda, that's impressive. But what would you say to someone who maybe doesn't have that ability to think so clearly in the heat of the moment when their anxiety is high, when they're feeling that rush of adrenaline and their heart starts to beat pretty hard? How do you coach someone to take that deep breath and deliver something or not be able to do it?
I get that question all the time. Despite the way I'm presenting this morning, I am an angry crier. And so I know that if I am emotional about a given situation, I know that I need to take a minute. I need to step away. I need to clear my head. Sometimes clearing my head means that I'm going to go in my office and I'm going to write down all of the mean and horrible things that I'm thinking, and then I rip it up and I dispose of it. That allows for more clearer, professional language to come through. I always encourage people to be very mindful about where they are on an emotional level, but you don't get to walk away from a situation and process and then come back and blindside somebody. If you're dealing with somebody that is behaving badly and it is a pattern of behavior, they don't remember the specific instance that you're talking about. They've already moved on to the next one. So instead, what I would do is I would say, Sarah, the interaction that you and I just have left me feeling a little hurt, but I just don't think that I am in a state of mind right now that I can have this conversation with you. I really do need to just kind of walk away for a moment and clear my head. But can you meet me maybe in the conference room or in the charge nurse office in 30 minutes so that we can talk about this? I don't want it to fracture our working relationship. We still need to be able to function as a team.
Would you even say that it's okay to maybe email the person if you walked away in anger to say, hey, can we talk after you've had that cool down moment?
So in some situations, yes. I would caution using that as a means of communication if you are talking staff nurse to staff nurse. If you are dealing with individuals who use email as a form of communication routinely, then it would be a feasible option. You're still raising awareness to the other person that something has upset you and that you want to work to resolve the conflict. But if that person is not going to receive that email for 24, 48, or 72 hours, we've missed our opportunity. We've missed our window. But that's where cognitive rehearsal really does come in handy. If you practice and you memorize these assertive statements or verbal responses against common acts of incivility, even in an emotional situation, you have the ability to pull that perfect tool out of your toolbox in the moment when it's needed.
That is huge.
That is huge. I think it's all about the practice and trying to capture something as real time as possible, because sometimes if somebody walks away, you may not ever get them back, right? And have that opportunity to talk to them. But I was just thinking about something. How do you capture either how many incidences are occurring, or how does one report that an incident has occurred?
Very good question. And I think that the answer to that is going to be dependent upon your organization. So we have a couple of different methods. If you are reporting an act of incivility from a provider, whether that is a physician or an NP, we put that in our patient safety reporting system. They've added recently an option to determine if it's a communication or a behavioral issue. Like I was saying, we have what's called the CORS system. CORS stands for Coworker Observation Reporting System. It's an evidence-based program out of Vanderbilt. Any reports that are put into our PSRS system will go to Vanderbilt. They will review the event report, and then they will, for lack of better words, tally those reports that are entered against individual providers. If we're talking about a provider that has only experienced maybe one or two reports, it's going to come back to our professionalism committee, and that provider is going to be assigned a coach or a mentor, and they'll have a informal coffee chat. They'll talk about the event itself, and they'll discuss ways moving forward that behavior doesn't repeat itself. So that's what we would do for our providers. If it's staff to staff, like staff nurse to staff nurse or PCA staff nurse, anybody other than a provider, if there is a coaching system in place on the units, and I say if because this particular training has not been implemented system-wide, it's request by unit leadership. So if we're dealing with a unit that has a coaching system in place, they report directly to their peer coach. That peer coach is given a form. And I put together, I use acronyms because I think that it's easier for people to remember. They need to document intention, impact, what individuals, who they were, and if they were bystanders or were they actively involved, and what's our plan moving forward. What are we compromising to, or what are we agreeing that we are going to do moving forward. And so the peer coaches on those units just save those in a private Google Docs, and then after so many, then it gets sent to the unit manager or assistant nurse manager. If we're dealing with a situation where a peer coach feels as though they are not trained enough or the behaviors are egregious and they are not able to manage this situation, then it will automatically move on to the management team. I also always coach all learners that if they're going to engage with another person. They're going to do peer-to-peer communication. I always suggest that they send a summative email to that person after the fact. After we've had our one-on-one chat, I am going to summarize how I felt, what was shared with me, and what we decided moving forward. I'm going to share that in an email back to that person, and that's going to serve as our anecdotal documentation. But I feel like it's also professional. It gives the other party an opportunity to respond if they feel like something was missing. So we have further engagement, and it does go to build trust. I also suggest that if staff are having to address their manager or assistant nurse manager because of perceived acts of incivility, they do the exact same thing. And all emails can be saved and used for anecdotal evidence if we need it for future.
So, Shalanda, I like that exchange. I like your language that you have. I feel like it's very spot on and it's not putting anybody on the defensive, which is great. Have you ever encountered somebody who doesn't want to be even talked to about it? Or
Absolutely.
Can you give us an example of if they respond negatively, what else do you do?
So I think it depends upon the response. Certainly, I preach the engagement approach. I want to be collaborative, and I also think that there's a lot of trust building that comes into having peer-to-peer engagement with one another. If at any point in time, either of the individuals fear for their physical safety, I ask that they disengage and go to a member of the leadership team for further guidance and assistance. Mm-hmm. I have unfortunately been involved with individuals in which they just flat out refuse to have some level of conflict resolution. Unfortunately, we are dealing with a situation like that now where there was some perceived unspoken threats. And in that situation, my guidance to the unit leadership is to involve human resources and the director of the department to further guide what should happen next with the staff. I will say, and I'm very happy to say, that is less than 1% of the issues that this organization sees. Most often, when a concern is brought forward to our leadership team, the managers have been coached to get feedback from the person that's reporting, but then you also need to go talk to the person that's been reported. Get an idea from their point of view what happened, and then we're going to seek out mutual agreement to help facilitate conflict resolution between the two. Oftentimes, they will call me to be that neutral person, just simply because two staff nurses are also going to be looking to their managers as though they are already biased. And because I'm non-punitive and I'm neither of the staff members report to me directly, it's a little bit easier for that neutral party to help facilitate good conflict management and resolution versus oftentimes the unit leadership for fear of retaliation or retribution or even corrective action.
What happens when those mediators can't resolve the concern?
Very good question. Again, it goes back to what the behavior was. Is there a history or a pattern? Has this individual already been coached and mentored? Is there an action plan in place? Because we can do informal action plans if we're already progressing towards egregious behaviors that are to the level of corrective action. Then we do unfortunately have to get human resources involved. But again, that's very few and far between.
Thank goodness, because nobody enjoys starting the performance improvement plan. Nobody enjoys being on a performance improvement plan. And, that really does affect, even their actions are already affecting everything that's going on. And now this is, ramping it up a little bit more. But it also has to be done. You cannot let people go unchecked, as you mentioned.
Absolutely. Absolutely. And I think the accountability piece, unfortunately, has been missed in historical cases of incivility in the workplace. And some of that goes back to what your organization's policies are. Is there a workplace bullying policy in place? And is it well crafted enough that it will help to guide our leadership in what to do when these acts are being reported to them? I always tell every group that change doesn't occur until people are uncomfortable. If you assimilate to a culture of toxicity, even though it doesn't feel good, that becomes what your norm is. So we've got to shake it up. And shaking it up is going to include starting to call out those behaviors and identifying the negative impact that it has on ourselves and our patient care. I always tell any civility workshop participant, along with those that are attending the leadership series, that change only occurs when people are uncomfortable. Part of making people uncomfortable is to begin to call out the behavior and the negative impact that it has on our teams and our patient care. I promise change will occur, but I can only make two promises. If you begin to call people out on their behaviors, it is going to raise awareness, and their level of introspection will prompt changed behaviors. Or these people are going to become so uncomfortable with their new work environment that they change where they work. Either one of those two changes is acceptable. I believe that you said, in light of our current nursing shortage, keeping a good nurse might be a high priority for an organization, but not if that nurse's behaviors fuels an environment of toxicity, because it's always going to lead to poor patient outcomes. Not all attrition is bad attrition.
That is true, for sure. So we talked a little bit about, leaders not knowing where to start or how to manage it, but also how do you get their buy-in? This is a very important part of all of this. What should leaders do to address these reports of incivility, and how do you get their buy-in?
That part was easy. I think because it is such a pervasive problem, not only in healthcare, but in society in general. Our leaders have long seen the negative effects of incivility. I started working at the medical center close to 8 years ago, and I wasn't here a month before she was our department director, along with our associate chief nursing officer at the time. But she asked me to replicate my doctoral work on one particular inpatient unit. And the change took about 6 to 8 months to see, but it was amazing. There were 3 queen bees, and there's always 3. I feel like they always come in odd numbers. And there was one definitive leader of the pack who had been historically just allowed to behave badly because she was a very tenured and skillful nurse. But when it got to the point where the unit was experiencing a very low level of staff satisfaction and a high rate of turnover, leadership started to take notice. So there was a buy-in very early on. Now, since then, we have gone through our CNO has changed over. We have a new one. I think she's been here close to 3 years now. And originally, I went to her to propose a organization-wide civility training program. So any individual, regardless of role and responsibility, would be required to go through civility training. And at the time, I feel like her list of priorities was a little too long, and so it did not take off the way that I expected. But there were some challenges going on in our operating room, and our medical director, along with our chief anesthesiologist, reached out to me for guidance. And so they used my civility work for full scale operating room culture adjustment. We call that the ORCA project. And we've gotten so much traction since that started a year ago. I am now being invited regularly to sit at the table with other physicians. I recently did mandatory training for all of our labor and delivery physicians, surgeons, and anesthesiology, along with every intern and resident. That then brought me to the table of the director of our Quality and Patient Safety Committee. And so when I described to him in detail every aspect of civility training, it did coincide with the CORES program out of Vanderbilt that we currently use for our provider accountability system. So when he heard that, he said, this is absolutely something that we need to adopt. Unfortunately, he can't give final approval, but it has gone to our president and our chief medical officer and our chief financial officer for final approval. So we are looking to implement this system-wide, hopefully in our next fiscal year.
Huge.
Yeah.
But I need more people. It can't just be me.
No, especially at a medical center the size of Ohio State. Have you thought about taking this further, like regionally, nationally?
Wow, that's a loaded question. The answer to that is yes. The challenge for me is in my current role or roles, I just don't have the bandwidth to go farther outside of the organization. I have done a podium presentation. I have done several posters. I have also presented at 2 other health systems in the city. Until I can actually have a fully robust trained team, I just don't know how much farther outside of our local area I can extend myself.
Which makes a lot of sense. As you mentioned, getting human resources on board, getting leadership on board was easy. But what other foundational issues did you run into or should a system consider, if they were interested in implementing something like this?
That's a great question. One of the first things I was asked by our executive business director is, what are the key performance indicators that we can see change in? Now, to answer that was very difficult. It's a subjective problem. When you're looking at metrics that are defined objectively, it would be very difficult for me to tell you what KPIs we can affect. I can tell you that we can affect retention. I can tell you that we can affect recruitment. I can tell you that we can become a workplace of choice, knowing that the Ohio State University Wexner Medical Center will not tolerate acts of violence and incivility from staff members, patients, or visitors.
And that is so big right now, especially from patients and visitors.
Yes. We have a very robust workplace violence program, but it is specific to patients and visitors. But what happens when the violence, whether it's verbal or physical, is coming from your teammate or is coming from a provider that should be on the healthcare team and a partner in providing care to the patient? I think one of our biggest challenges is that we don't all speak the same language, and we need to. Team Steps is a framework that we can use to start communicating the exact same way. I always joke, I always tell my groups, I'm going to teach you guys how to cuss.
Yes.
Because when people are being cussed at, they will stop and they listen to you. And everybody gets like, oh my gosh, is she really going to do that? And I say, yes, but we're not going to use vulgar language. We're going to say the words concerned, uncomfortable, and safety.
There we are cussing.
Yes, we are. And it matters. And it is absolutely helpful. That is one outside of cognitive rehearsal. There are 2 or 3 team steps communication strategies that we implemented in the operating room research project that has been hugely successful.
Let's back up to that cussing. Let's use those words as if you were teaching the group. What are the phrases?
I'm concerned about the order that I received for this patient. It makes me a little uncomfortable to discharge them knowing that they don't have the ability to get this follow-up treatment or medication. I really think that this is a patient safety issue. I do not want the patient to leave knowing that they may end up right back here.
Andrea, could you imagine saying that or even hearing that? We've been nurses for a long time. Could you imagine how well that would have worked for you?
Oh, I would have loved that. Having the scripted language like that really helps. And it would be nice if, from hospital to hospital, since we know, many of us move around a lot, that it was a consistent language across all hospitals. So you don't have to learn a completely different language when you go somewhere else. And especially with physicians, when they're rotating amongst, various hospitals, it would be nice to be able to do that and have them understand. I always wonder, when you do use that scripted language, what is plan B? That's my fear if they don't respond. What's a nurse's next step?
Well, generally, once you cuss at them, they stop the line. They listen. They understand that using the words concerned, uncomfortable, and safety, that carries a different gravity than to just say, I'm not sure that this medication or this treatment plan is going to be the best for this patient given this entire list of social determinants of health issues. I think that maybe we need to look at X, Y, and Z. Generally, there's pushback then. That's when the physicians say, well, this is standard of care, this is best practice, and this is what I'm ordering. Get case management involved then. It's then that the nurse can come back and say, I am very concerned. I'm uncomfortable with the treatment plan that this patient is on. I really think that this is a patient safety issue if we discharge them knowing that they don't have the resources to obtain this follow-up care. Generally, then, once you cuss at them, they stop and they listen.
This is so great because I just feel like, this is just such a hot topic right now. I think it's been something that has unfortunately been evolving over time and has just grown and gotten worse and worse. So I love that you're tackling this, and I wish more organizations were going down this path for the safety of the staff and their mental health and the patients as well, of course. So as we wrap up our episode, can you share how you envision, the future of nursing by continuing to adopt these techniques and create civility in the workplace rather than incivility?
Because we are a very highly stressed profession, functioning with competing priorities and very limited resources, it is so easy for the toxicity to continue. But if we start demonstrating the very behaviors that we are expecting to see in return, it is also just as easy to make it a more healthy workplace environment. Our organization already has a very robust list of interventions in place to help with mental well-being and resiliency and mindfulness. We just have to be consistent with utilizing those interventions and preaching them, not just have a page on our intranet or our learning management system to identify what the interventions are. We have to not only speak it, but we have to live it. We have to walk the walk. It will be just as simple for us to change the culture to healthy as it was to allow it to be toxic.
That is so true. And one of the things I used to always tell my nurses, we're all ingredients of a pie. You cannot have one person missing. Otherwise, it'll be too salty, too sweet, or too bland. And so I don't know about the rest of our listeners, but Andrea and I are so incredibly inspired by you, Shalanda, and everything that you're doing. I love that Ohio State has you and that you're able to pour into the nurses and create this next generation of civility and really make a difference. You may not feel it every day, but you are making a difference. So thank you so much for being with us today. Thank you for spending time with us during your busy schedule. we are incredibly grateful. Thank you.
I appreciate it. Thank you guys so much for having me. This was fun.
Thank you so much. I love all of your insights and everything that you're doing, and we wish you the best of luck in your continued journey in helping nurses in your organization. And to our listeners, as always, we welcome any feedback or suggestions, so please reach out to podcasts@aacn.org.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's online nursing community forums, offering support, inspiration, and sharing of best practices online, with information available at www.aacn.org/AACN communities.